Okay, good afternoon. So we'll carry on with the implication for brain examination of different conditions. We're going to look at fetal infection. Fetal infection is an illustration of you can only see what you're looking for. It's true for every condition, but it is particularly true for infection. Also because the signs you're going to look for are variable with time. So not only should you be able to focus on the ultrasound pictures or other form of imaging, but you should also be able to work out the biology and the timing of the infection. The example we're going to take for most of the talk is that of cytomegalovirus. One, because this is the most frequent infection. 1% of all pregnant women would do a primary infection during the pregnancy. Second, because it's quite a stable and frequent transplacental passage of 30 to 40%. And third, because that's where the semiology on ultrasound is the richest. So there are two very different situations to make the diagnosis. The one situation where you are seeing an image on your screen and you are questioning the likelihood of an infection. If that makes sense, because it's an image that can be attributed to infection, the diagnosis is at the tip of the needle. You do an amnio, it is or it isn't. The more difficult situation, putting ultrasound in a more unstable position, is when you are following a pregnant woman with serial serologies, or you're just asking for one serology, a one-shot thing, and you see what is compatible with a primary infection, and then you are asking the ultrasound to tell you if the fetus is infected, one, or if the fetus is infected, if the fetus is severely infected. Those situations are very different. The first one is easy, and we will mention a couple of things. So, ultrasound picture, and if you want to know which infection to target, you do a maternal serology. The only thing you need to suspect further the infection is the presence of IgG. Immunoglobulin G is the second line antibody built up, and that's the only one which presence confirm that the woman has been exposed to an infection. IgG is specific of the infection you're looking for. IgG from parvo is very different from IgG for CMV. It's very different from IgG from toxo, and so on and so forth. IgM is the most useless test one can think of, and the most unreliable. A woman has been exposed to an infection, she will build IgG. So the only situation where, looking at a picture, you can be 100% sure that this has nothing to do with the infection you're thinking about is when the woman has got no IgG. If this woman has got no IgG and you see an image that is evocative of an infection, a particular infection, no IgG equals no infection here. And you don't need to do an amnio for that infection. Is that 100% clear? Then you've not lost those 30 minutes. Otherwise, if you go by following a woman in pregnancy and you start playing the game of serologies, again, the most unreliable test is IgM. IgM is non-specific. For example, for CMV, if this lady had primary herpes, genital herpes, she's going to carry IgM to CMV or whatever for a month. Again, seroconversion means appearance of IgG. Appearance means it wasn't there before. And the challenge you face is to find a previous sample showing that there is no IgG at that time. Clear? If you are unsure, you got a test that will help you is IgG avidity. The avidity of IgG is to bind the IgG in the serum of this woman with an antigen you have in the lab. You bind them. There is a liaison between the two, and then you break that liaison with urea. If it's a recent infection, the liaison will break very easily, very fast. If it's an old infection, it will stay tight. And the avidity, the tighter it is, the higher the avidity. If the avidity is above 80%, the infection is older than 3 months. If the avidity is lower than that, the infection is earlier than 3 months. 3 months is quite a good unit of time during pregnancy, and it will help you out in most of the cases. If you cannot conclude, again, the answer eventually is at the tip of the needle. However, IgG is not linearly correlated with the time from infection. This only works with toxo. Doesn't work with parvo, doesn't work with CMV. It goes all over the place. It is present or absent. You cannot deduce any kind of timing looking at the kinetics of IgG. So it is useless, but completely useless, to repeat IgG measurements. It's there or it's not there. Once it's there, there's no point to repeat it. Whatever change you see doesn't tell you anything. So once it's there, you don't have a previous sample, you use avidity. Out of that, there is no hope. If you are in the first trimester and you see IgG positive, IgM negative, usually you're out of the water. She had CMV before or whatever else before. She had the infection before. So outside very peculiar circumstances where you will question potentially periconceptional infection, you're fine. If she's got IgG at the beginning of pregnancy, it's fine. She's immune. If she's immune for any infection by CMV, she's protected. Toxo, she's protected. Parvo, she's protected. If she's immune for CMV, she is partly protected. But don't get into that. And again, the only reassuring situation is IgG negative. If you have a doubt on maternal symptoms like flu-like illness, fatigue, whatever, wait for 2 weeks, do the IgG again, still negative, you ruled out the infection, right? If you are hoping that ultrasound is going to tell you if the fetus is infected, you're going to be disappointed. These studies have all been done by people who knew what they were looking for in women who had been exposed to infection, and that is the performance you can expect from ultrasound. At best, 25% sensitivity for the diagnosis of infection. So you cannot do anything without the biology. One reason for that is that the infectious process is a dynamic one. When the woman catches the bug, she will go into about 6 weeks incubation. Then that bug is going to try and go through the placenta, so the placenta is going to struggle first. Once it's overwhelmed by the bug, is going to let it through and behave itself as an abscess. So the earlier signs you may see is placentitis, thick placenta, heterogeneously looking placenta. Then the virus goes through the umbilical vein to the fetus, and the second target online is the kidney. That's where the highest affinity is. And when the virus hits the kidney, what happens is usually a decrease in urine production, not an increase. And therefore, oligohydramnios is much more evocative of an infection than polyhydramnios is. Not often thought about, but this is more characteristic than polyhydramnios. Usually this is transient. It works for any kind of infection, especially CMV and toxo. This poor one with very bright and small kidneys here is the only one I've seen with such a severe nephritis due to CMV. And then, and only after that, will the virus be released in the fetal urine. So 6 weeks from the mother, a couple of weeks from the placenta, a couple of weeks to get to the kidney, and eventually spit it out, pee it through in the amniotic fluid. And only then you can expect to do an invasive prenatal diagnosis and recover the virus from the amniotic fluid. So the two dogmas for an amnio: never before 6 weeks after maternal infection, for all the reasons we've just said, and avoid doing that before 20 weeks because before 20 weeks fetal urination might not be sufficiently established to pass the virus in sufficient amount, even for molecular biology. 6 weeks, 20 weeks. And then, if you know the fetus is infected, and the only way again will be amnio, then you're looking for clinical forms of infection, either benign, mild, moderate, or severe. And you know the features from neonatal papers. As usual, fetal medicine prenatal diagnosis is first a transposition from neonatal data back to the fetus. Asymptomatic means easily no signs whatsoever. Severely symptomatic with any virus, and especially CMV, is severe IUGR, microcephaly, ventriculomegaly, hydrocephalus, the full blonde picture. But the moderate form will require some more attention, that you will easily skip the signs if you're not searching for them specifically. Meconial peritonitis, hepatomegaly, splenomegaly, and of course hepatitis and thrombocytopenia are not going to show up on any form of imaging, so you will eventually require some invasive testing. It is important because the asymptomatic fetuses, as the asymptomatic neonates, have a very good prognosis outside the risk of neurosensory hearing loss. Neurosensory hearing loss does not mean deafness. You should ban deafness from your vocabulary when you discuss with pregnant women and CMV. Once you've said deafness, they will hardly believe you if you say it's a good prognosis. And they'd be right. Deafness is absolutely rare, very seldom. What is not seldom is neurosensory hearing loss. A degree of hearing loss doesn't mean deaf, especially because it is usually on one side only, unilateral. And the probability for that is 5 to 10%. No other sequelae for asymptomatic neonates, and therefore truly asymptomatic fetuses, and the aim will be to define an asymptomatic fetus. Looking at the big study from Bologna, looking at 600 women with primary CMV infection, known as such, with ultrasound follow-up, you see that in this team, very much used and interested by the problem, not knowing about the result of the amnio, again, the sensitivity for diagnosing infection by ultrasound is only 15%. And even worse, I would say worse, is that the specificity is far from 100%. You will find false positive findings, ordinary ones, like small for gestational age, like hyperechogenic bowel, anything, and attribute that to infection, which is sentencing this fetus to death in many countries, especially in the second trimester. So ultrasound alone doesn't work for sensitivity nor specificity, and if you think that this is due only to the moderate form that you will not see, if you look at a group of very symptomatic fetuses, still sensitivity is low, less than 25%, even in very experienced Hansen centers. So forget about ultrasound alone. And if you are really embarking into the diagnosis of infection, you have to go through an amnio at some point, and specifically at the right time. 6 weeks, 20 weeks. Once the virus is recovered there and the fetus is actually replicating the virus, you can look for signs of viremia or septicemia and tissue infection, especially the bowel, the liver, the heart, the lungs. If you look at the chronology, therefore, of these lesions we've mentioned so far, placentitis oligohydramnios are among the first ones. Again, thick placenta, more than 4 centimeters at the thickest, with both hyper and hypoechogenic lesions. Ileus peritonitis, ascites, liver and spleen enlargement and calcifications is the second step. We'll go through that in a minute. And more invasive, even calcification of the lungs or the myocardium with a dilated heart, either by myocardial infection or anemia or both. We'll go through that, and eventually IUGR. First, hyperechogenic bowel is very primitive, and since this seminal paper by Amuabad in the Lancet more than 25 years ago, the best way to go through that is to decrease the gain down to complete darkness and only consider bowel that would only disappear at the same time or after the closest bone. If the bowel disappears before the bone, you do not call it hyperechogenic. And that'd be useful every time you change your machine. Most of hyperechogenic bowels are nothing at all, completely normal outcome, whether the fetus has swallowed some particles floating in the amniotic fluid or nothing else. The vast majority will be normal. Dead fetuses often show a hyperechogenic bowel, but this is not a diagnostic challenge. Severe IUGR do the same because of redistribution and hypoperfusion of the bowel. And then depending on which specific interest the referral center that published the paper is into, you will find predominantly infection, you will find predominantly multiple malformations, GIT malformations, obviously, and also chromosomal abnormalities. So there is no reliable statistics to tell you in the general population what is what. The vast majority are normal, and that's the most important. Looking at liver and spleen is not very often in our practice. And again, since you're only going to find what you're looking for, you have to specifically look at the spleen and at the liver if you know the fetus is infected. You're looking at hepatomegaly and splenomegaly, and the literature is very disappointing and not very much up to date. If you want to look for references, you have to go way back. The way to measure the liver is not really anatomic, and this should change with MRI, but so far you go for a parasagittal plane from the gallbladder up to the diaphragm, drawing a straight line. Everything below 4 centimeters in the second and early third trimester is normal. If you want to look at the spleen, you go on an actual plane of the abdomen at the level where you would measure the abdominal circumference, but taking the full size of the stomach, so usually slightly above the usual abdominal measurement. And you will look for, first subjectively, you will look at the stomach. Very often in those cases, the stomach appears displaced towards the midline. And second, very often the size of the stomach is smaller than expected, although the abdominal circumference usually is normal or slightly above the median, even if the other measurements are small. The spleen, you will therefore look in this corner of the lower rib, in the corner between the lower rib, the spine, and the stomach. You will make sure this is the spleen by showing the splenic pedicle and you would measure the largest diameter of the spleen. Again, second and early third trimester, anything that is below 4 centimeters is acceptable. But again, I mean, honestly, who sees the spleen if you're not looking for it? Usually. Nobody looks at it. Very rightly so, most probably. IUGR is a very specific point in the pathway of infection, because IUGR can result either from a severely infected placenta and a mildly infected fetus. So the placental insufficiency is not primary, is secondary to the infection. The baby is not growing very well because of that, but the baby is not symptomatic. Or the severe growth retardation could be due to severe infection and hypometabolism because of liver insufficiency, for example. So this is not enough to say it's good or it's bad. If you look at the pediatric literature, at those babies in which growth was assessed at birth, 131 in 20 years, not very much, but you see that those with a normal CT scan and normal neurological examination were small in 37% of the cases, whereas those with an abnormal neurological examination or CT scan were small in about half of the cases. Statistically difficult to interpret, and the answer probably comes from the exploration of the fetal biology, especially platelets and liver enzymes. We'll come back to that. At the final path of infection are the lesions of the central nervous system, and specifically from the brain. So that can be weeks or even months after the beginning of infection. And therefore, when you know that the fetus is infected, you should look at the brain not simply in an actual plane of the brain, because if you are waiting for microcephaly to develop, the baby will be born before that shows up in 95% of the cases. This is a late event. What happens first is decreased growth of the brain, so not microcephaly, but microencephaly. And microencephaly will lead to microcephaly because the growth of the bones will not be stimulated by the growth of the brain. And what you will see, even in an axial view, is actually space around the brain. The pericerebral spaces will be large, although the baby is unlikely to be big. You will see the proximal hemisphere, although usually you don't see it because of this vacuum between the bones and the brain that shows you the proximal hemisphere. Very often the first sign is mild ventricular dilatation, but this brain, if you don't know that the fetus is infected, you could easily go through not noticing that this is a rather small brain for the size of the skull, and that the ventricular rims are slightly echogenic. And if you turn in a coronal view the same fetus, you would see that there is a very large space around the brain, that the main fissures, the Sylvian fissure, is very, very smooth and poorly developed in the early third trimester. And if you move to a sagittal scan, you will see that this is even flatter than you thought and very smooth indeed, with lissencephaly. So this is a kind of a so severe and typical aspect that these, if you're looking for it, you're unlikely to miss. Above the biometry of the head is the view of the fetal profile with a sloping forehead, more evocative of microcephaly. The features can be more subtle. So if you start from there, you would see that not only it is a small brain, but you see that the germinal matrix shows a small cyst, periventricular cyst, that the all echogenicity of the white matter is heterogeneous, that there is some hyperdensity at the lower end of the ventricles, that the choric plexus are very bright, very small towards the lower part, and that again the germinal matrix is all blown up with a small cyst here. Those cysts are sometimes very subtle, and you have to look for them. The periventricular hyperechogenicities are characteristics. They are the initial aspect of periventricular leukomalacia that is going to become cavitations very soon and potentially proencephaly. Calcifications disseminated in the white matter are very frequent, and necrosis of the ventricular rim and the choroid plexus is also very evocative. And the typical aspect of the calcifications of the vessels of the basa ganglia are also something quite characteristic, but not always very severe when it's isolated. You can see here that the cortex is the level of the Sylvian fissure. Sylvian fissure is not even visible, and there's lots of hyperechogenic aspect here, necrosis with cyst. This is a counseling emergency, and you should be as careful and reassuring as possible, because these severe forms are only 10% of all cases of infection. The vast majority will be fine. And second, imaging now doesn't mean ultrasound alone. Imaging means ultrasound and MRI. And there is no debate, and there is no conflict as to which one is better than the other. We've discussed that this morning. It is particularly true for infection. You are looking for negative predictive value here. You are looking for reassurance. The statistics are working for you, and they are working for the fetus, because 90% of them will be fine. But you need as much reassurance as possible to avoid iatrogenic termination of pregnancy or unnecessary anxiety, and that's where MRI is. This portrait is of the same lady by two different great painters. They show different aspects of her personality, and they are just as beautiful one or the other. It is the same for the two techniques. They will show different things, and if they are convergent, to point out that this fetus is normal, this is exactly the answer you're looking for, nothing else. And that goes along not only with imaging, but also probably fetal blood analysis in terms of prognosis. Yes, if the infection started late in the pregnancy, not showing very much on the ultrasound, if you are looking for polymicrogyria, lissencephaly, and heterotopia, there is no discussion that MRI is much better than ultrasound in the third trimester. Necrosis of the caudate nuclei you can get to with either one or the other technique, but be careful that at this point in time you have to face the responsibility and not give a prognosis based on isolated findings on the MRI no one can interpret so far, namely hypersignal in T2 sequences of the temporal lobe. It's not because the temporal lobes is the main target of the virus, especially implicated in deafness or neurosensory hearing loss, that you have to see false positive images. So no report about that. And isolated ventriculitis with a septated ventricle and no other lesions on the ultrasound is not a prognostic sign. So if you want 100% reassurance, you have to have together normal MRI, normal ultrasound. You get a 95% negative predictive value. The 5% that are missing you will find in the fetal blood by showing normal platelets and normal liver enzymes. A couple of cases, 32 weeks, decreased fetal movements. There's a big dilated heart, there is a mild ascites, and there is a small stomach bubble that seems to be quite central. Very high peak systolic velocity, so this fetus is anemic. Is getting a transfusion from 6 to 13 grams. There is a big spleen indeed, there is a big liver, and there is a small septation here. This baby was born at term after being treated in utero with CMV. This is the first transfontanelar ultrasound. There is an isolated cyst of the germinal matrix, and this baby is now 6 months old. He's got normal hearing performance and is completely asymptomatic. Another case with IUGR in early third trimester, all measurements, normal Doppler, thick placenta, hyperechogenic bowel. If you look at infection screen, IgG are positive for everything. If you look at IgG avidity, it's only low for CMV. You're requesting a booking sample. She was positive for IgM but negative for IgG. Therefore, she had a seroconversion between the first and the second trimester. Amniocentesis is positive. Another typical example of an early infection, all the measurements at 22 weeks are below the 10th centile, thick placenta, very little amniotic fluid, hyperechogenic bowel, and if you go through that BPD again, that characteristic image of too much space around, too bright, the rim of the ventricles, and a cerebellum that looks hardly developed and very small as well. Normal Doppler, and a brain that shows hyperechogenicities of the periventricular areas, calcifications in the white matter, and too much space around the brain. This is not the same. This is another baby that was born asymptomatic, although it shows calcification of the vessels of the basal ganglia. These, as an isolated finding, are not of prognostic value. The amount of viruses in the amniotic fluid is not prognostic. When you look by PCR, you see virus accumulating in the amniotic fluid and dead virus as much as a live virus, so the only correlation is with gestational age. The viral load in the fetal blood is not consistent yet, and the only biological factor that is independently associated with the prognosis from the imaging is the thrombocytopenia. So fetal blood will be useful in the workup of an infected fetus with CMV. Second infection is parvovirus. Again, you're looking at primary maternal infection. About half of the women of childbearing age are immune, and if they are immune, they are protected. It comes every 4 to 5 years to your country and your area, especially in the winter, and it is usually declared in the daycare centers for small children, and it is known as the slap cheek syndrome, where these babies have got flu-like illness and very bright cheeks, and that is something that must be declared. Then the prospective risk of vertical infection is about 30%, but the risk of asymptomatic fetus after maternal seroconversion is about 10%. The symptoms are occurring through invasion of the bone marrow and the liver, and all the stem cells are the progenitors of the red cells are infected, and this causes central anemia. Central anemia and potentially myocarditis can lead to hydrops. Myocarditis is the only direct teratogenicity of this virus. You would make the diagnosis by the appearance of IgG. IgM is therefore completely useless here because it's very inconsistent. And once a woman has IgG built up, you will scan her every 2 weeks for at least 3 months, looking for signs of anemia in the fetus. The earlier the diagnosis, the better. So that will rely on MCA, PSV, serial measurements, plus or minus of the signs of hydrops. Hydrops in parvovirus is very specific. It is a completely blown up fetus like the Michelin guy with a massive and tense ascites and a very thick frontal edema. Very severe anemia, recovers very well after intrauterine transfusion. The diagnosis will rely on fetal blood sample showing the anemia. You can recover the virus from fetal blood, and at the initial fetal blood, you should definitely measure the reticulocytes. If they are high, you are likely to come back again with another transfusion. If they are low, you are very likely to do another or more transfusion. You know that you can use the calculator either on your own machine or through the internet on perinatology.com, not perinatology, because you will have to buy push cars and things like that. It's a different website. And once you're back with normal MCA PSV and you still see high drops, you will look at the heart. If the heart went from a thin dilated heart, which is common in anemia, back to normal, it's fine. If, on the other hand, you see progressive thickening of the myocardium, you might be in the 5% of the cases where, despite recovery from anemia, this fetus is going to develop viral hypertrophic myocarditis, and this fetus or this neonate will die, whatever you do. And that's when the high drops is not resolving. This virus is not teratogenic for the brain, but the very low hemoglobin is often, because it's a central anemia and pancytopenia, there is low platelets, and therefore there is a risk of brain hemorrhage, and only those with brain hemorrhage may develop brain lesions following parvovirus infection. Toxoplasmosis, to finish with, is far less prevalent. It's 3 per 1,000, especially Southern Europe and North Africa. The IgG are very reliable in terms of kinetics, so the interpretation of serology is much easier than with CMV. The very severe form with encephalomyelitis and microphthalmia are very rare nowadays. The earlier the infection, the more difficult the passage of the parasite through the placenta, but the more risky the infection is, with a crossing of the two curves at around 20 weeks, therefore the worst time in the pregnancy. And the same goes for eye lesions. You would look for non-specific features as seen with CMV. If you look at the brain and you look for brain lesions, usually they are much bigger, patchier, echogenic foci than from the CMV. The eye lesions you would look for, but you're very unlikely to find them isolated. I don't think it's ever been reported. But it is well seen part of massive destruction of the brain. And CMV can hold for weeks with stable lesions of the brain, whereas toxoplasmosis, once lesion starts in the brain, the evolution of these is very rapid, and scanning every 2 weeks will fix the prognosis very rapidly, unfortunately. And I think we should leave things there. We're on time for coffee break, and I thank you for your attention. We'll be back for the questions and the case studies after the coffee break.